everybody. So welcome to our December brunch. I think we are December, aren't we? Yeah, 4th. So today we've got a huge panel. So we've only got 2 of us from the forum side of things, because we thought we'd get as many as we possibly can from the PCN side of things to talk about diabetes care and PCNs and all things primary care and diabetes. So I'll go around and let everybody introduce themselves, and then we'll do our little icebreaker question before we get into the chat, just whilst we're waiting for people to join. So shall I go around my screen so we don't all talk, because there is a lot of us? Okay, so I'll start. So I'm Beth. I'm a lead diabetes specialist nurse in Wiltshire now, which sounds odd. Amanda, your turn.
Yeah, I'm Amanda. I'm a diabetes specialist nurse in Medway in Kent, and I'm currently on a comment out into a primary care network in Rainham in Medway.
Yeah, so Hannah next.
Hi, I'm Hannah Bieber. I'm a consultant pharmacist at Leeds CCG.
Nikki, I've got next.
Hi everybody, good morning. I'm Milne. I'm a primary care diabetes specialist nurse in central Manchester, and 20 plus years experience as a practice nurse with a special interest, and a member of the Primary Care Diabetes Society.
Partha?
Yeah, I'm Partha, consultant diabetes in Portsmouth and one of the diabetes colleagues with NHS England.
Cool, and then we've got Claire at the bottom.
Hi, morning everyone. My name's Clair and I'm a diabetes pharmacist at Leeds CCG.
Cool. So we've tried to get as many as we possibly can perspective-wise, haven't we, Amanda? And we know there's tons of people that could have been here today, but we can't obviously have everybody involved because we've only got 1 hour, and we can't have so many
speakers. Please add all your questions in the chat if you're watching, all of you guys that were involved.
Yeah, so any of the questions from Facebook, we'll ask these guys. We've tried to have a bit of an MDT approach. Cool. So for our little icebreaker question, our question was going to be today, as we did Christmas movies last year, what is your favourite Christmas dinner item? And who shall go first? Amanda, you go first because you're first on my thing.
It's got to be stuffing. Love a bit of sage and onion, maybe wrapped in bacon. Very nice.
That's a bit posh. Okay, I think mine would be, I don't know, probably the humble roast potato, which is not very adventurous, is it? Anyway, never mind. Okay, Hannah, you go.
Yeah, tough one, guys. I think the gravy, lots of gravy.
Oh, that's a good one, actually. Although they're quite pain to make. I'm just like gravy granules type of girl. Okay, Nikki?
So I'm probably with Amanda on the stuffing, and my mum makes the most amazing haggis stuffing. And the irony is my mum, we're from Manchester. My husband is Scottish, but it's my mum that makes this haggis stuffing. And when it's our turn to go up to Scotland for Christmas, we take my mum's haggis stuffing up with us. So it's Coles to Newcastle. So, and also just let you into a little thing. Hannah has already prepared a Christmas dinner this morning. I've seen a picture from her kitchen. So she's been busy basting a turkey this morning, haven't you, Hannah?
Super pharmacist.
What I like to do on the weekends.
Partha?
So for me, I think I'm going to go straight to dessert. Actually, I think I really like I always love my Christmas pudding, and I think especially if it's like citrusy and stuff, I love it. So I think that is probably something I always look forward to. So it's the end when you're sitting there. You feel fat enough, but you still have your dessert and you're watching some really nonsense on TV. It's lovely. That's what I really look forward to.
Yeah, no, I'm not a Christmas pudding person myself, but
See, that just has to be done for me. Once a year, you just, yeah. And of course, with the Ferrero Rocher around you as well. Yeah, just in between bites.
Yeah, and some whiskey too.
Absolutely.
Claire, you're on mute before you speak. Oh, that's good. You did know.
It's a difficult one. I was going to say stuffing, but I actually really like the turkey as well, because it's about the only time of year we have it. And I'm not sure why. We should have it more because it is really nice.
Because it's dry.
I know, it's
It is.
not with
It
gravy.
depends how you cook it. I can't
And it's
cook.
nice the next day as well, and as leftovers or going into curry. So yeah, I enjoy the turkey and cooking that.
Cool. Okay, so now we've done that, we've got quite a few people watching. So I guess we'll get straight into it. So I was going to ask Partha, because obviously NHS England worked with the group that wrote the document that we kind of wanted to talk about a little bit today. And we've had a few people kind of asking, obviously it was called Best Practice of Diabetes Delivery of Diabetes Care in PCNs. I might have got it. We'll put the link, it's just quite a long time.
Yeah, you could have made it a little bit shorter.
But a lot of people are kind of saying, is this mandatory? Do we have to do this in PCNs? You know, was it written as something that we all have to do by a certain time, or, you know, what's going on with that?
So I think let's make one thing very straightforward. First of all, very little in diabetes care is mandatory, apart from providing good care, right? And all you do have is good practice. So I think the NHS keeps changing, right? And every few years you have a new name for something. And those of you who have been in the system long enough will know about the PCTs and the CCGs and the SHAs and the, you know, there were so many names. There were PCNs or whatever, and we're back to PCN. So fund holding, you know, we can go on and on and on. So I think it's not mandatory. It never will be. But what we say to people, I think it's fair to say primary care networks are one of the new currencies in town. It may or may not survive in the future. It may become something else. But primary care networks are in different phases of evolution, is probably the polite way of putting it. Some are much more advanced. Some are like, okay, I don't even know what a PCN is yet, or I haven't signed up. So what we're saying to people is that if you've got one, and if you've got a plan, amazing, please crack on, as long as you're doing good diabetes care. If you don't have anything and you want to have a look at something as guide, here is something that people have created, and it's a mixture of people who've done that. So that's the approach we are taking. You know, it's not mandatory. It's a bit like saying every hospital should have inpatient diabetes team. It never was mandatory. We have pushed it, so it becomes common good practice. So that's the way we would sort of look at it.
Cool. So we've got two of the authors here today that wrote the paper, and like we said, there is a whole host of you guys in the team, wasn't there? But I don't know who wants to take. Hannah or Nikki, do you want to kind of explain the document, where we can maybe find it, how people can use it, those kinds of things?
I'm happy to take that question. So yeah, just to give a nod to there were 6 of us. So Lorraine Avery, who's in Portsmouth, diabetes specialist nurse, Naresh Kanamilli, who's a GP with a special interest, Sarah Ali, who's a consultant in London, and Sarah Alicia, who's a dietitian, and Hannah, who's with me today. So the document sits on the full document sits on the Diabetes UK website. It also sits on the Primary Care Diabetes Society website. And we've also, the full document is fairly lengthy, and we've got lots of examples of good practice. We call it Bright Sparks. And I think those are really helpful when you're looking as a PCN as to what things would be useful for you. And we've also done an at-a-glance fact sheet as well. So it's a 2-page document that summarises the key points. And also we've done a how-to article in the Journal of Diabetes and Primary Care, which talks about how you can look to adopt some of the philosophy of the document as well. I don't know if there's anything you want to add, Hannah.
Yeah, I think you've covered that. You've covered that really well. I think the pyramid of care is probably something that I think most people are starting to get their heads around. That's probably a good place to start while you think about how you structure things out and where things sit. But you might have a question about that, so I'm not going to go into too much detail. Don't want to preempt you guys.
Oh, I was going to say that can be the next question. Go for it.
Right.
Yeah.
So
what is in the document? How will it help us? What does it tell us?
And what do the tiers look like?
Yeah, so the tiers basically lay out sort of the bottom tier, tier 1, is where we hope that we'll start to embed some good basic care for people living with diabetes, that we're doing that in a robust way. We're not getting this sort of pockets of good care without sort of consistency. So we hope that we'll embed that. At tier 2, we're hoping to start to develop a new level of care at that primary care network. And we hope that this will sort of compensate with what's needed in the tier 1. So it might be, if you've got a practice that can't do insulin initiations, for example, there may be help that comes in from the primary care network level. Or if you have got practices that are maybe flying a little bit more with some of these things solo, then you might start to develop a little bit more complexity within that PCN level. So there's an exercise there in sort of mapping where you're at as a locality, as a place, and then starting to think about how you start to complement those things. At tier 3, we hope that we'll start developing as, well, in a lot of places this already exists, but a tier 3 where we've got integrated care. So that could work one of two ways, in my opinion, and I've seen it both ways now. So either you can look to bring specialist care out of the hospital into primary care, or you could start to develop some specialists, some more specialism in that tier 3, which sits in primary care but is starting to really look at developing some real complexity clinics, and starting to drive forward the idea that really quite a lot of diabetes care shouldn't really sit in the hospital, and that we try and deliver that closer to home as much as possible, with the skill sets and the competency that we need to build up to do that needs to be given some thought. And then tier 4 would be based on the Portsmouth Super 6 model. So it's just what we normally would find in the hospital: inpatient care, antenatal, type 1, those sorts of things. Although we could discuss whether type 1 should also move out in the fullness of time. But yeah, I'll leave it at that.
It's just probably important to say that the this sort of PCN level, we've called it the DIAS team. So it's the diabetes support team. And a lot of people have thought that this is an extra layer that we're going to fund and bring in. But what we're saying is that across a group of GP practices, you've probably got somebody with a special interest, be that your dietitian, your pharmacist, your practice nurse, your GP. And what we're saying is it's that those people with that special interest that will lead the PCN team. And this applies for any other long-term condition as well. So in a group of practices, you may have one practice that's really good at respiratory care, another practice that do well with diabetes, another one that do dermatology. So it's about best use of your resources, so that you've got those people there that can help upskill and train people. And this really, although this was a document we were asked to look at doing pre-COVID, we started, didn't we, in January before the first lockdown. This really is a document that will enable PCNs now to help with that, with the backlog, and to move forwards, because it's about sensible organisation of your current resources, really.
Yeah, it sounds really interesting. I think you guys, so Amanda's already, well, you're kind of doing a sort of project like this, aren't you? And Hannah's definitely, and Claire definitely doing it. So I don't know if you guys want to give a bit of experience about how you kind of have set it up, how it's been working.
Yeah, so ours is in the very, very infant stages of DIAS. So there's a nurse and a pharmacist, and we're concentrating on upskilling primary care at the moment. So all of the practice nurses, the GPs, the PCN pharmacists, we're putting them on education programs and doing clinical supervision in their clinics, so that they can then learn about how to maybe initiate GLP-1 in primary care, because the issue that we have at the moment is in Medway, GLP-1 was on specialist initiation only for ages on the pharmacy, what do you call it, you know, like the medicine management thing. So primary care never started GLP-1. So then the community DSN teams are getting sort of 89 referrals just to do a GLP-1 start, which is, you know, fairly easy process, could be done in primary care, could free up that time for the community nurses. So I think that's, you know, that's been our main focus, is getting people upskilled so that they can do those 3 tablets and GLP-1, and maybe even a basal insulin start with in the next year or so.
And that sounds a bit like
I think I'm definitely seeing that in my area too. Just so many, even referrals for SGLT2 starts, and it's like, really, they've been around for a long time now. It's not the best use of specialist care, perhaps. But yeah, sorry, Claire, what were you going to say?
Sorry, no, I was just going to echo Amanda. That's very similar to where we're at in Leeds, and certainly the challenges of even the GLP-1 initiation, which they're not specialists in our patch but green light. A lot of people don't feel confident in initiating them, so some of it is going back to those trying to upskill and support primary care to be able to confidently initiate GLP-1s as well as manage people with diabetes. We've taken a similar approach probably to yourself, where we're trying to get that early diast through tier 2 of the tier model embedded into practice, and we've been fortunate enough to have some funding from NHS England to improve the NICE-3 treatment targets, so we're linking the work into that to try and improve the treatment targets and PCNs with some funding, but to use that funding to help with some of the training and upskilling to pump prime the DIAS model, so that we can then look at rolling that out across the city. But it's about bringing that care closer to home, isn't it, and delivering it out in PCNs and using the staff, obviously like yourself, PCN pharmacists, nurses and some GPs as well, to try and get them working together at that PCN level, which is a new way of working. Practices are very individual, aren't they? They used to working on their own, so this is a big challenge for primary care to work at that PCN level, where it's given us a good focus. And the DIAS model, Nicola and Hannah, thank you, it's very timely to all the authors that were involved in that, because it was a good framework for us to follow. It just happened to land at the right time for Leeds.
Yeah. So there's been a couple of questions come through.
Yeah. Oh, you've got that one. That's fine.
Yeah, is that okay? Okay, so one of the questions is asking, how have you found implementing the model? In my experience, practices are finding it challenging working as a PCN and don't currently share existing staff. Do you have any sort of ideas of how to overcome that, the barriers to that, and tips on how we can bring the PCNs together a bit more?
I mean, the PCNs are in their infancies, aren't they? So, I mean, likewise, I think that sometimes it can help to have a bit of structure, because they're not really quite sure how to manage this. And actually, in some ways, I mean, I've had a lot of interest in our model of care, not just for diabetes, but actually for many different long-term condition management. So people have been approaching me to discuss how we're going about that, which is really, really positive. So I think that there's that side of things, but I think, there is a lot of chat about left shift and what do we do about that, and that the resource isn't following the workload. But there is still lots of pots of money where you can release some funds, so QOF being one, the DES being another. There is money there. They have got funding for these extended roles in primary care, so using those sensibly and looking at their populations and seeing that's actually the role of that is the role of the PCNs. You have a responsibility to be doing that for your population, in my opinion. So I think that's definitely something that needs to, there will be difficult conversations to be had around that, I think, and we've already started that certainly on our end. But there is a reasonable interest in doing this, and I think, like our treatment target project, we're not doing this in all 19 of our PCNs at the moment. We're doing a soft start. We're going to do 4 PCNs, prove the concept in some early adopters, and then hopefully people will see the benefit, and we'll have our own examples of how well it's working in addition to the examples that might be in the document.
And I think it's looking at the staff that you've got that are shared as well across the PCN pharmacists are often shared, they're shared across practices, and that's a new resource. So looking at that additional role reimbursement scheme funding, can you tap into some gaps there? We know that not all PCNs are fully spending that money. So is there some additional resource they can get through that? Because that is shared, that is staff that are shared across the practices. And like Hannah said, it's about trying to look at what staff you've got, but also tapping into that interest that there is out there. Some PCNs are really keen to already have a model similar. So this has given them a bit of a framework to work towards. They realise that they might not have enough insulin starts per practice to keep staff skills and competence up in insulin starts. So to do that at PCN level makes much more sense than trying to do things like that at practice level. So I think there's a real ambition out there from some people. There's some early adopters really gunning to go, and like anything else, it's about proving that it works before we're trying to roll your model out.
Yeah, it's always the same. It always comes back to, oh, you know, we need more money, we need more staff, all those kinds of things, doesn't it? And I think we were going to ask Partha actually, because there's a lot going around at the moment about the care processes and QOF processes and things being paused, again, potentially for the COVID boosters and all the other work that there is possibly a backlog of, and the effects of this on diabetes care. So Partha, do you have?
Yeah, I mean, I think we are in a very slippery slope right now. I mean, I think, you know, in the beginning, it was totally understandable. We were hit by a pandemic. Nobody knew what the heck is going on. We had to vaccinate. We had to stop things. So I fully understand at that point of time when people had to stop doing X, Y, and Z. We all did it. We did it in hospitals as well, right? We stopped doing so many clinics. We were all on all hands, and we didn't know what we were dealing with. And as a consequence of that, and frankly, it's nobody's fault. We're in a pandemic, right? So we've had a 35-40% drop across the board of care process. So, you know, if anybody's saying, oh, care process has been going on as normal, it's not. And it's not anybody's fault. It's just physically possible to do it. We know that from our own clinic lists in hospitals. Same things happen in primary care. I think the problem that right now we have is that we seem to be going back to a situation where, right, we have to do a booster now, so let's just stop everything again. Which to me, 21, 22 months in, you're thinking, hang on, you must have planned for this a little bit better than, oh, let's just go back to primary care again. And I think primary care are put in a really, really tricky position right now. What do? Do you turn around and say to the population, I'm not going to do vaccines, which is seen as, you know, the way the media said, go like, oh, you're really bad primary care. Aren't you bad people not doing vaccines? Or do you say, well, to do that, I have to stop something? Absolutely rightly too. And in which case you go like, well, how dare you stop diabetes and heart failure checks? So how are they supposed to do it? And I think for me, what would have been sensible is to say, right, we've done what's happened. Let's make a proper plan for the booster dose. Or if a variant comes, we all knew this would probably happen. I think banking on the fact that I don't think anything is going to go wrong anymore is a bit silly. And we are here. And my question back to everybody who's making the decisions, I don't judge anybody for having to pause what it is. What I do, however, question back is the lack of planning to do that. So what do we do now if, let's say, there's another variant turns up in April? Do we pause it again? What happens if they go like, right, we have to restart the vaccine program again? You know, worst case scenario. What do we do? Do we stop it again? And how far do we've got patients who have not had any checks done for 20 months now. 20 months, 2 years, some people. Nobody's fault. It is what it is. But I think on this round, I must say that I'm not over the moon, so to speak. I would fully appreciate what's gone on over the last 20, 24 months. And, you know, it's not any primary care or practice nurse's fault. They're having to make a choice, but they're being put in a really unenviable position, in my book, due to lack of planning. And let's make one thing very clear. Let's talk about the science. Care process is linked to mortality. I'm not even talking about amputation, it's death. End of story. Good evidence-based which says and the other thing is when people go like, don't worry, Partha, we're going to prioritize the right patients. I'll tell you what that does do. It opens up health inequalities straight away. That's what primary care are brilliant at, not doing that, basically saying we will do at a population level everybody's care process. What it does do, we do that, right? In hospitals, we do prioritization. Guess what? The biggest gap in deprivation is in specialist centers because of that. You do that in primary care. You in a chronic disease like diabetes, you are in deep doo-doo land. I mean, things like, and I'll finish with it, things like, I was talking to somebody that said, well, just look at the people with high HbA1c. And I said, okay, well, that's not really a marker to prioritize your patients. If that's your plan, you're going to miss truckloads of people who are having hypos at home, number one, for starters. So again, I don't at all blame primary care for having to make that decision. It's a tough place to be in. But I do, however, really wonder about the lack of planning we have. 22 months in, we are now saying we need to stop things to do it again. Well, then we have a problem. We have a big, big problem on our hands about catching up. I mean, how far do you want to do catch up? So yeah, it is what it is, but it's not going to translate well for a lot of people with diabetes.
Yeah, I just say it's like a constant, like the waves just keep coming, and now the wave that we've got is dealing with this 2 years of backlog of people that haven't had anything done for 2 years, and so they're coming through to us with high HbA1c.
Yeah. And can I also just mention that's the people that we know that have got diabetes. So you know, we were part of a group in Manchester that showed that in the first lockdown alone there were 60,000 new cases of type 2 diabetes that we've not picked up because we've not been doing the health checks and the routine blood tests. So there's an awful lot of people out there that have got diabetes that don't know about it yet as well. So there's that backlog as well, isn't there? Not just with the people that we know have got diabetes.
Doesn't help that we had a blood bowl shortage as well, so bloods have been not being done either. There's a question on Facebook from Jane Diggle. She's asking, maybe booster vaccination should have been outsourced so that primary care can get on with their normal work. What do we think about that? Who do we outsource it to?
I think that's above our pay grade, isn't it?
Yeah, absolutely.
Pfizer, by the looks of it from the profits. No, I'm jesting. I think that there's all those trained staff out there that were tapped in to help in the vaccine clinics, that were, you know, non-healthcare professionals, the volunteers, the St. John's ambulance volunteers.
And the army involved as well at one point, doing vaccinations in the first bit. So it's not all been primary care, is it? There have been some outsourcing.
Yeah. So it would have been capping in on that and what worked well, and keeping that enthusiasm up from all those people who step forward to volunteer and to scale up. It doesn't need to be a healthcare professional given that vaccine, does it?
I couldn't agree more. I mean, I couldn't agree more. That's the planning, isn't it? That is the planning. You know, we should have done this 6 months ago, basically said, what can we do outside primary care? Outsource it, go to volunteers, make sure you paid volunteers, get people retired to come out, you know, do so much stuff. You can't go back to primary care to do it, but we are. So there, that I 100% agree. We should have planned this better. And to me, maybe we should need to think about a national vaccine force, right? And as I said yesterday in a meeting, they were like, well, vaccines are the priority. I said, yeah, let's not forget it's the National Health Service. It's not the National Vaccine Service, right? There's plenty of health care outside the pandemic. We are now starting to miss, and we are all picking them up as we go along. So.
And that's the issue, isn't it? We need to get used to this new normal, as it were, and we're going to be having vaccines, you know, probably for a long time to come yet. And people with diabetes are high risk of mortality if they contract COVID, especially if they've got a high BMI or a low BMI or a high HbA1c. So, you know, we really need to be looking at those people, especially to try and avoid more COVID deaths.
So with the PCL, the DIAST or anything, is there any role that those teams can play in looking, like stratifying the, I know Partha said obviously that that's maybe not the way to go, but how can the PCNs or the DIAST teams help support this backlog and get through some of the mud that we're stuck in at the moment?
So I don't mind taking that. I mean, you know, the person that's taking that role within the DIAST team, you would want to be looking. It is difficult because not everything is, you know, you want to look at your audits and identifying your high risk. And I know Jane Diggle just asked a question there, and Jane and Pam have done a very good guide of how to prioritise. And it is difficult because, you know, we don't read code levels of deprivation, and we've been very poor at read coding sort of ethnicity and things like that. But it's a start, and you would want to be looking at running the audits and then trying to risk stratify and get those people in. And I think it is very challenging because one of the things that I think also really helps with having this care more local and having this expertise in your PCN teams is one of the things that we've found very difficult is where we've started putting clinics back on. people haven't wanted to come anywhere near the hospital because they've been so fearful about getting COVID. So certainly when we first reopened to do some community clinics, which were based at the hospital, we were lucky if one person came to that clinic. We were having a really high DNA rate. So really, we have got to be trying to deliver care closer to home, and where people, you know, are more comfortable with accessing care as well. And also looking, you know, more at the, I know it's been unpopular, people are saying they want the face-to-face reviews, but remote, and also looking at group consultations as well remotely, so that we can deal with the, you know, we're doing injectable starts, and can we do that across the group? Because there is so much work. And I think we're all finding, aren't we? I know, Beth, we were on a conversation recently where people's HbA1cs have just absolutely shot up, and, you know, so it is more complex.
Yeah, and it feels like every patient you review is just an insulin start now, or something, because their HbA1cs are just too high, and they, you know, they're just too poorly. So obviously we had the draft NICE guidelines out a couple of weeks ago, maybe last week now, wasn't it? Which obviously we were all super excited about. Do we think that there's going to be a place for maybe using technology to kind of pick these patients up maybe more in PCN land, primary care? Don't know who wants to take that, maybe Partha.
Yeah, I mean, there's a few things that you can use to find the patients and stuff, but I think what you're probably talking, are you talking about like using levers and stuff?
Yeah, you mean like palm tools and
yeah,
what's it called, Primus?
Yeah, so there's a few tools out there that can help stratify patients. So you have palm tool, you have Primus, you have Ardens, there's all different ones. I mean, some of the pharma companies will give you access to tools that will pull patients from EMIS and divide them into high-risk patients that you need to see right now, and then those patients that have maybe got a better picture, so maybe are not so urgent, so that can help. And those really high risk patients are the people that the DIAS need to see. I don't know, is that what you would think, Nicola? Is that?
Yeah, absolutely. You know, so that's where the DIAS comes in. So very much at that level, it's you know, where the level 1, the tier 1 is where you would want people to be able to deliver good diabetes care, basic care. And then that second level might be for your women of childbearing potential. It might be for your people that have got renal impairment, or they've already got established cardiovascular disease, where you can just put in that that higher level of expertise.
We've seen quite a few. I saw Sarah Gregory yesterday saying actually she was using tech and stuff a lot more in her type 2 patients, and they've got something coming out soon, so that might be also something to consider. Did you want to say something, Partha, about technology?
I think the way things are set, if the NICE guidelines go through, this will become part and parcel of a lot of people's lives. You know, I think I've already said to our DTN colleagues and everybody is that it's not a secondary care business anymore. You can't turn around and say everybody with type 1 is going to get technology, and a lot of people with type 2 will qualify for it, and then say, well, everybody needs to come to a specialist center. It's just not going to fly, is it? First of all, we can't even look after people only who've got type 1, forget about type 2. So I think we need to now move to the place where we say, okay, you know, somebody asked me, what about the training? And I said, how much training do you do when you give people blood glucose monitoring sticks? You just give them out.
Yeah.
So what I want people to do, I think it will be part of a learning curve for people. I think it's technology. People always will, what do I do? Well, majority of people, you all know, if you give them a YouTube video, they're absolutely fine to put it on themselves and crack on. But with type 2, you'll probably need a bit more support about putting it on, understanding, etc. So I think it is going to be quite big. I think the type 1 community will revolutionize their lives, right? CGM for everybody. I mean, we are going to be way ahead of any other country. And then if you tie in, I mean, to be honest, if you look at the way it's set for children and young adults, I mean, pretty much everybody's going to be on a closed loop on there. You go to a CGM, you go to a pump, you connect it, it's done. So it's finished on that one. It's with the adult side, I think the NICE guidelines, with the data we are getting so far is pretty amazing, the closed loop trial. So that world will change. I think the game will be when it is how it evolves into type 2, people on insulin, people in residential homes, nursing homes, picking up hype. I think it should make life better, actually, but people need to see that it makes their lives better rather than seeing it as an extra piece of work. So it will take time to fly, I think, in the type 2 community. Plus, they don't have the patient power or support behind them like the type 1 community has. Type 1 community peer support is amazing. They will drive each other out. Type 2 will take more time. Type 2, I think, will be dependent a lot on clinicians. Type 1, not necessarily. So yeah, I think that's how this will go.
And there's a lot more people in the type 2 community, isn't it? So, I mean, 90% of people with diabetes are type 2. So there's thousands and thousands of those. So it's going to take a long time to probably get infiltrate to everybody that needs it.
100%.
Goes back to that point about group clinics, though, doesn't it? Around actually starting to create that peer support for people living with type 2. So I think group clinics for tech is the way forward, and it probably sits at the PCN level as well.
Absolutely. I think that's the only way you can do this at scale.
People are going to ask about funding, though. This is always going to be a thing, especially when new medicines get the go ahead for different things. So when Bieber came out first, I know we were like the last CCG in the country to authorize Bieber on medicines management, but I think we've done well to get it back to how it is now. But I'm just dreading trying to get the same thing through for type 2.
So that there is a different thing. So don't forget that when we did the Bieber one, there was no NICE. We just did it on our own. So CCG is quite understandably would go like, well, who the hell are you to basically tell us what to use? And we obviously had our battles at that time. But I think this is different because I think it's a bit like an SGLT2 inhibitor, right? It will have pickup, but you can't. It's very difficult for people to clinically deny NICE, because what NICE are saying is that glucose strips are basically poorer care. Okay. So they're putting down number 3 on the list, not even 2, just a straight number 3 for everybody. So for type 1, you need to have a very strong clinical justification locally to say that we're not giving it. We've got a few things up our sleeves as well with pricing and stuff, but don't forget, let's talk about the type 1 population. Nearly 55% of type 1 are already funded and they're getting it, right? So that's not an issue. And if you look at CGM use, it's around about 10%. If you take kids and everywhere, 7%. So 65% of the type 1 diabetes population is already funded from existing budgets. So I don't see a major change there because internationally markets will saturate around about 70. 30% of type 1 diabetes patients will always say no thanks, or got lots of other issues on their plate, mental health issues, don't want it, happy with what they got, not fussed about it, got other priorities in life, will never want it. So I think type 1 wise, I don't think there'll be a major challenge. Type 2 wise, you're absolutely right, there will be, but I think it would be very difficult, and you will have variation. That's where the variation will kick in. So what our policy will be the same. We'll watch and see how the variation tracks, after which we will pick them up with the ICS now. It is not going to be CCGs anymore. So lesser people to go and talk to. So you have 44, not 216, which is what we had to go through with Libra. So yeah, so I think that's where we are. So that's what will happen, I reckon.
Do you think there's some savings there as well for the fact that with people living with type 2, you might not use it continuously? You know, you might actually just use it for an intermittent period to guide a clinical decision and then stop it. So that would be less expensive. So
true, absolutely. And I think people, so that's what I say to people, you got to use it as a interventional tool. That's what you need to think about it. So if somebody's got, you know, for example, dementia, etc., they're in a nursing home or whatever, you can use it as a, you know, as a block to see where it is rather than all the time. So there are many ways you can use it. So yeah, that's the way I would probably look at it.
Yeah, I had that discussion the other day actually about, Nicola, with a nurse, like she was going, I'm doing Libres, you know, 1-to-1 with patients. And I was like, why? There's absolutely such a waste of our time. Like, use the reps, they will happily do it all for you. Yeah. You really don't need to be using
I think, Beth, you make a very important point. And I say this to all clinicians, we need to let go. We really need to let go. We need to stop thinking we're the only ones who can do it. We can't. I mean, we can, but we just want the resource to do it. So in which case, encourage peer support, encourage the companies to come in and do it. You know, the one thing we don't have, and I always say this, is applicable to type 1 or type 2. You know, the 3 planks on which we sit is, you know, self-management, peer support, and access to trained professionals. And the NHS spends time, effort, and money on number 3 when we don't have them. We just don't have them. So, you know, for example, a slightly digressing, but let me give you an example, because you've got specialist nurses here. We've also got Hannah and, you know, Claire here. I was asked a question recently, went to a meeting, and they went like, we put out a job advert for a nurse. I couldn't find anybody, so we didn't fill it. And I went like, what about the pharmacist? And they went like, what about them? And I went like, what? Why didn't you get a pharmacist to apply? Why have you just made it a nurse? Surely they can help with the safety side of it. And I think unless you're thinking like that, you know, so I think to anybody who's listening, I always say, as you talk to people who are using it, I don't sit down and do one-to-one starts on Libra, and trust me, I do Libra starts every day. I've got a full-time clinical job. I send them most things by email and then send them a script through the post, and I go like, best of luck, and they do amazingly well. Okay, you know, variations around it.
Like when they're always like, they have to do education before they get a Libre, and I'm like, do you know what? Actually, just giving someone a Libre, for example, or any tech is enough education sometimes to just let them knock themselves out with it.
So true, so true. So yeah.
Yeah, and I was just going to say, we've very successfully been using the current 2-week free trials with a lot of our people with type 2, and I've not had anybody who hasn't been able to put it on, you know, just go away and learn and put it on themselves, and then we've looked at the data together, and you know, just that 2 weeks has been really helpful for so many people, so make use of that as well.
Just a couple of things on Facebook. So Vicky was saying incident starts were always done as a group back in 2005, so group tech is a great idea. And Jane has said it will require lots of, I'm guessing she means Freestyle Libre, it will require lots of training in interpreting and acting on results from things like Freestyle Libre for healthcare professionals and people with diabetes. The value of any measure lies in what is done with that measure. So yeah, it's no good just having it and not actually interpreting. Yeah,
there's loads of training available, like glucose diet, like the DTN did tons of training. It's all available free. There's just no excuse now for not being able to go and access all of that, and that's something I hear all the time, and it really grates a little bit. Like, I don't have training. Well, it's out there, and I think NHS England, or you know, DTN, they all put together a huge program to combat all of this, didn't they?
Free training can count towards your revalidation.
I've done quite a lot of modules. It is really it's quite time heavy, but it's so in depth, and I think it covers everything you do need. So you can dip in and out. You don't have to do, you know, all of the modules. You can just pick the ones that are relevant to you. There's like quite a lot related to pregnancy, for example, which might not be relevant to your role, but yeah, they're really short, easy videos to do. So it's all available.
Just another message about the using pharmacists in nurse posts. Nurses sometimes are paid in a lower banding than pharmacists, and especially a nurse prescriber doesn't always get the same banding as a pharmacist prescriber. So that's just something that might come up if you
true, but I think then it depends as to how you're playing around with the money a little bit. Do you go for the higher banding but lesser hours, which is better than having nobody in the post? I think people need to be a bit more creative about it. So I think we have done that locally. You work it the other way backwards, right? You fit the money to the person, and then you go back and say, okay, we can't fund, let's say 36 hours off the pharmacist, but we can probably get 24. Is that good enough? Well, to me, it's better than having 0. So, you know, you still will have, you know, you've made a step progress further, then you can collect some more data and go back about filling the rest of the hours. That's what we did with our podiatrists. And I think people, that's what I keep on saying to people, is that if you just walk away saying there's nobody, then you will never take the next step forward as well. So, yeah.
And there's so many pharmacists out there that are really interested in diabetes. It's a really untapped resource, I think, isn't it? We really need to start making more use of our pharmacists.
And certainly in the document we talk about dietitians as well, so that's another resource. So, you know, there's quite a broad spectrum of other roles, so yeah, do think outside the box.
Can I ask something?
And also go the other way, can't you? Okay. Sorry, go on.
Can I ask something? What do you, I mean, I'm going to ask this question to all of you in return. I mean, you mentioned the you know, bits about dietitians. Do you think dietitians are very much hampered by the whole rhetoric that's out there about just go low carbs and it's sorted? Do you think that because you got a lot of clinicians who are not dietitians in that space, rightly or wrongly, you've got doctors, you've got nurses, you've got pharmacists, you've got a lot of people involved in that space feeling they know the answer, you know, thereby saying the dietitian doesn't know enough. Okay, we don't need a dietitian because we've solved it. Which is ironic because I don't see a lot of dietitians trying to do what doctors and nurses are doing, but I see a lot of doctors and nurses trying to do what dietitians are doing, believing it's wrong, you know. So do you think that hampers their sort of recruitment? Because lots of people go like, well, I can do this. I'm sure I can have a go at this, because I mean, how tough can it be to advise about diet?
We found it really hard to recruit a dietitian. Our post was out for ages and we've only managed to get a part-time dietitian. I don't know why people are not excited to come and work in diabetes. Now, come on. But yeah, it took us ages.
Yeah, I think that there is also, I mean, there's a lack of staff and stuff, but I just feel like you don't see a lot of, I mean, you mentioned about posts, I don't see a huge number of posts out there. So, but anyway, it is what it is.
Yeah, and
one of the things we found with dietitians is that I don't know if it's the BDA are a little bit stuck behind the times, but they don't have much. Obviously, to work in diabetes, they have quite an extended scope of practice, which we've come across recently. So they might be doing a lot of things, changing like insulin carb ratios, those kinds of things. But actually, like we can do as nurses, we can become prescribers. They can't do that in dietitian land. And obviously they have an extended scope of practice, which the BDA don't have a lot of guidance about. So it becomes a little bit difficult for them. So I don't know if that's maybe something to do with it as well, that maybe they struggle to recruit into for that reason. We've come across that a few times lately with our dietitians.
Actually, Claire works in a virtual prescribing clinic. Maybe Claire, you can just talk a little bit about how that works with the dietitians. So that's probably a good example of how you can work your skills mix to work nicely for you to get the most out of your dietitians as well.
I mean, certainly in the community service I work in, they use the dietitians that they've got quite smartly. They see patients, obviously they do the dietary advice, but they also initiate oral agents and titrate insulin, but under the, you know, I suppose the supervision support of a prescriber. So they're really well trained up and the different treatments, and will come and say, you know, want to prescribe this, what do you think if they're unsure? But there is actually a document that allows them to safely titrate and increase doses up of oral medicines. I think that PCNs would all love to have a dietitian working within them. I think that I don't believe for a minute that I would ever dream that I could do the job that a dietitian does. It is really hard, like Amanda says. I do know my limitations, and certainly I think it's really challenging for practices and GP practices and as well. They would all love to have dietitians, and they struggle. That is the bit they really struggle with, is some of the dietary advice and that structured education programs. So if they could recruit dietitians, I'm sure they would, because their hours funding allows them to do that within the remit of the PCN roles. I think it's just there is a shortage. So that's and I do wonder sometimes, like you say, maybe is it the dietitians as a collective, do they have enough strong enough voice in diabetes, and perhaps that's maybe where it needs to be driven as well.
It brings us to a point on Facebook here from Pauline. She's saying this restrictions is why I left dietetics and became a physician's associate.
For any dietitians associate. Any dietitians that are listening, the BDA released a document about extended scope of practice within diabetes not very long ago, and I'm not sure if everyone even knows about it, but we had to go and search that out and create like a whole new job plan and things around extended scope of practice. So if anyone's not aware, do go and have a look or contact the BDA about it.
It's a shame Sarah Alicia is not here, because she was part of the document, wasn't she? She's a dietitian, but she's on holiday having sun in it.
That's there.
If it's warm this time of year.
Yeah, Jane said she's been working alongside health coaches and things. I was going to say, when we were talking about banding, actually, that is the other way to go. So if you can't get a band 6 or 7 or whatever, you can use nursing associate roles, HCA roles that can take a lot of the work from us. So we were looking at getting a HCA role to kind of do tech support kind of stuff role within, I think, to take some stuff away from the nurses and things, you know, where you can, so that we're there for the more complex things maybe. So that's definitely something.
There's a suggestion from Debbie White here saying, alongside a national force of delivering vaccinations, maybe there could be a national register for clinicians with diabetes expertise that could be called upon. Lots of experience out there, not fully utilised by the PCNs, in my opinion. Like a bank of diabetes specialists.
I think that's kind of like peer support. I think people need to tell people about peer support much more and get that in, because, you know, although it's not clinical advice, what people can learn and help each other with is another thing that we definitely can tap into. You were going to say something, Partha?
No, I mean, I think these things always are good ideas, except that you will always have people, well, what about heart failure? What about rheumatoid arthritis? Why can't we have a bank for this? Why can't we have a bank for that? I think the bigger question is, I think I always say, you take a step back. We're talking about the primary care networks and stuff. I think somebody is, you know, I was having a chat with Twitter, and then somebody's put in there, oh, everything needs an overhaul. And whenever people say we need an overhaul, I always go to national policy. Okay, tell me why. Not from your own anecdote, because your clinical life is not good. Tell me from the point of view of a population for diabetes, things are not going right. If you can show me it's going the wrong direction, we will change it, right? The reason we put so much focus over the last 3-4 years on technology access in type 1 is because type 1 outcomes are poor. End of story, really poor compared to type 2. So when people come to me and go like, oh, you just favor type 1, don't you? And you go like, well, no, I'm just focusing on the people whose data are the worst. That's the reality. So now what you do have is that due to the care process we have in this country, and whether you do it in a primary care network, what we're doing with the document, for example, is saying, okay, these are the priority young type 2, this, that, everything, type 1, because those are the areas we can make things better. So if you look at the care process we have over the last 7-8 years, this is what I say to everybody, and there is evidence after evidence to tell you that what primary care has delivered. We're one of the best performing countries in diabetes. You know, it doesn't feel like that sometimes when you read all the papers, but our amputation rates are low, our cardiovascular events are low, our mortality is low. Diabetes people's top reason for dying anymore is not cardiovascular events. They're getting admitted to hospital is not due to cardiovascular events, your hospital admission. So you can't have anything better than what primary care has delivered. So when people come and say, let's change everything, and they go like, why? Why do I want to? Okay, I'm very happy to change a lot of things, but I love change. But you've got to give me a reason that this change will not set back the benefits we have had for so many people with diabetes. And I think that's what the primary care networks can do really well. You build on the progress you have done, not ditch everything else you do. Okay. So when people say that, oh, I don't have the resource path to do all, that's a separate debate. That's something that you need to lobby with government, get the resource, etc. We don't turn around and say, I have no resource, thereby I'm not doing it. But if that's what you're doing, then, well, then you're in an era of prioritization, in which case the NHS as it stands is dead, because you are now prioritizing based on your own right or wrong. Right? You're making your own markers as to who you're going to see. Those who shout loudest will come and see you. Guess what? All this deprivation, ethnicity, well, so I think that's the way to probably look at it when people talk about what are the next steps? What do we do next? The next steps for me is then the question of, here is a primary care network, here's an opportunity for everybody to work together, here's a document to try and help you with some priorities set by. And you always get the conspiracy, and finish with this. What do you get? As soon as you publish it out, I remember the first time I published it, you went like, Papa, why have you written it? Are you even qualified to talk about primary care? And I was like, well, you clearly haven't opened page 1 because I just wrote the bloody foreword. That's all I did, okay? So it's quite fascinating is that if you're set in a mindset that everything is wrong, you'll never improve things. You can't. Because always we just don't have enough people, which is true. So that's the way I probably look at it.
Just one last note to say that multi-morbidity clinics could be a way forward to try and reduce, because there's obviously, we're talking about heart failure and things like that just now. Maybe if we did clinics all together, then you could save time and save resources and that. But I think that's probably about time to wrap up. It's been a really, really useful 55 minutes. I don't think, is there any last things from the panel that anybody wants to say before we close?
No, so I'd just encourage people to look at the document, even if you think, oh gosh, that's a big foot, just at least look at the at a glance one. And I'm assuming it's on the DSN Forum website as well.
There will be links to it on ours. Yeah, absolutely.
So have a look at
it in the chat as well.
Yeah, look what works, and as Partha said, let's build upon what we're already doing well.
Absolutely, and thank you all to our panel members. Thank you so much for coming. Thank you everybody for listening.
Enjoy your Christmas
loads of views. They've stayed on for the whole time as well, so it's very engaging. Thank you very much, and we'll see you next time.
Yeah, someone's put at the end, she's going to go away and have a look.
We're going to go and set up a PCN DIAS.
Cool. There you go.
Thank you, everybody. Have a good weekend. Bye-bye. Bye.
Thanks for the invitation. Bye.
Bye.
Thank you. Bye-bye.